And I think we have got just basically some messages for those of you doing polypectomy and colonoscopy. So do you need to be able to do colonoscopy to do polypectomy? If you cannot do colonoscopy properly, you cannot do polypectomy properly. And why should you be able to do polypectomy properly? Well, because if you can't do polypectomy properly, then patients get negative outcomes, and patients have to come back for repeated procedures, and patients have missed cancer potentially within their polyp, and patients get surgery for polyps which don't need surgery, and they could have had an endoscopic approach, and they could have avoided the negative outcomes of that. Well, there's a lot of data out there to suggest that this is the case. There is no direct evidence that said, I observed X person and he did a bad polypectomy, and then this patient 6 years later got a post-colorectal cancer. Okay, 6 years, bad example, 3 years later. But there is, of course, surrogate data, and that surrogate data suggests that there is significant variation between endoscopists in their rates of immediate and delayed complications, that patients are getting referred to surgery for disease which is not invasive, and therefore did not need surgery, and therefore these patients were over-treated. Patients getting post-colonoscopy colorectal cancer following incomplete polypectomy or missed lesions, and I think both of those is relevant because, of course, missed lesions comes into the quality of the colonoscopy. And incomplete resection, of course, this is something which this course particularly wants to help you avoid. Recurrence, and of course, these patients, they have multiple procedures. The nice picture from Ronan. What does that show, Maria? What do you think? So just you have to, because I've just shown you a random picture, right? So that could be anything, but let's take the context in which we're discussing here. We're discussing the context of unexplained variation in polypectomy practice.
Yeah. I mean, is it the white thing is on some filter or something?
Yeah, the white thing is an ulcer, yeah.
Yeah. And
what's this?
It's polyp.
It's a polyp, so residual polyp.
Yeah.
And so this actually was taken for another reason 2 weeks after a polypectomy was performed in this patient, a cold snap polypectomy. And so this is a cold snap polypectomy ulcer, healing nicely, and on the edge is a nice piece of polyp that was not. I'm not asking you this because you almost could become the queen of scar assessment, but Andrea, what do you see on the image is here?
This is an image from a rectal retroflexion. We can see a scar. We can recognize it because it's whiter than the background, and the vessels disappear, colonic vessels disappear. And we see a sessile lesion, just, I would say, 2 centimeters above the squamocolumnar junction. And yeah, so this is recurrence after polypectomy, hot snare polypectomy, potentially. Yeah.
I agree with everything you said there, apart from the 2 centimeters, which I would go with a centimeter. But okay, fantastic description of that image, almost a perfect description of that image. Very impressed. And the only thing I then want to ask you is, you said polypectomy hot snare. How do you know that?
Because of the scar thing.
Yeah, I mean, I fully agree, but it's interesting for people out there why you just pulled the word hot snare. How do you know that? That's incredible how he knows that based on this image. But you're absolutely right. A cold snare polypectomy, it would be an interesting thing to do in this location of this type of polyp, to do cold snare polypectomy of something that was clearly bigger than what is shown here. That's one. But 2, also, indeed, the scar is different looking in cold snare polypectomy, and it's much less pronounced than this. What do you see on this image? A mess is a good answer to the question. It's a good answer to the question. But what does it look like has happened here?
I think probably the lesion was too invasive, and someone tried to resect it, and I think we have a tattoo there. I don't know. It's like the blue thing. I don't know. It's just the elevation, submucosal elevation, but someone tried to resect it and was too superficial. Probably it's too invasive, and yeah, it's a mess. I don't know what's happening.
What I agree with again, I agree with everything you said. I'm not, so some things that look like this are not invasive, right? I mean, this could either be invasive or this could be something that's been attempted before or is some sort of very, very fibrotic. This for sure could be either. A lot of polyps that I've ended up failing on, they're a lot, makes sense. I've failed a lot of polypectomy, but the ones which are extremely difficult, I would say 50, like most of them, like 80, 90% are not invasive, because otherwise I hope I wouldn't have started them. More of them are just extremely fibrotic from some reason, be it in previous attempt, be it whatever. But everything else, I agree with what you said. The tattoo, maybe it's just injection in the wrong place, I think. So this, if you should summarize this whole image, first of all, in terms of, well, let's say in terms of polypectomy technique, how would you summarize it?
So if you don't resect it at all in one piece, then it's really hard to do a polypectomy after, and I don't know, it's really difficult then to the other colleagues or for you to resect all the lesion.
Yeah, well, that's for sure a very important point. You're on to patient experience, because this patient in this situation has probably already been once or twice, is now come again. This time has failed. Clearly it's failed. This is not going to be salvageable, the situation. And so probably this patient going for surgery, we already said that this looks like it may be benign. But the other things it says to me are poor technique, overconfidence in ability, and incorrect choice of technique, perhaps, because I think you were driving at the fact that maybe this should have been attempted for ESD rather than what it looks like has happened here, which is just polyp shaving. As John says, give it a bit of a haircut. It hasn't definitely addressed the base of the polyp. There's poor injection technique on display here. There's scraping of polyp tissue on display here. And of course, actually critically, there is poor lesion assessment on display here. And so all of the problems that we are going to talk about, the solutions for today, are on display in this image. And if you end up with something like this, then you better hope that you did it in a center where there's someone that can bail you out, because if not, the patient going to get a negative out. This is what we want to achieve. So this is a endoscopic resection scar without a hot endoscopic resection scar without any evidence of recurrence. So this is what you should be experiencing at your surveillance procedures, unlike the first image. Patient is ready in the room, so we'll have another few minutes. I think, Xander, maybe you can put the scope in to start the procedure, and we'll join you shortly. I think it's important to say that there's a huge amount of data out there now to suggest that post-colonoscopy colorectal cancer is a problem, that the rate in England is significantly lower than the rate in other countries. And I think main important thing about the Netherlands and the UK is they know what their rates of post-colonoscopy colorectal cancer are. We, in Belgium, we may know it, but the publications come many years after the event, and we have no global strategy to deal with it. So we are working on that, of course. And finally, things I wanted to say about in the introduction before we get started are, if you are making these judgments for patients, you must understand that the judgments you're making are subjecting the patient either to the correct treatment, and that's down the middle of this diagram, or that they are undertreated or overtreated. We've already talked about this, but in terms of polypectomy, this is where you are undertreating the patient by doing something endoscopically when they clearly needed something else, like surgery, or piecemeal when they needed en bloc, or overtreating the patient where you just say, well, I want to do ESD, and therefore I'm going to do en bloc when it's not necessary, and I'm using resource, and I'm subjecting the patient to adverse events which they didn't need to be subjected to. Surgery where endoscopy was potentially indicated, very increase in morbidity, potential mortality. Multiple lesion assessment, something we've talked about in terms of green endoscopy, also very important. I think that we really need to think, actually, in the end, that we don't have great polypectomy quality indicators.